Dear colleagues, dear students, we continue the psychiatry lectures from the University of Pécs, 5th year, first semester, and this is the last lecture on the lecture series. This is about suicide. Suicide is one of the human possibilities, we can say, and death can be chosen in human life. The humans can have the possibility to voluntarily finish their lives, and while the meaning of this choice is different, Camus, the great philosopher, says that the greatest question of philosophy is around suicide. Suicide appears to be the most personal action an individual can take, although paradoxically, neurobiological and social-cultural factors play an important role in the etiology. So we can see suicide from a philosophical perspective as a possibility of the human to choose death, and we can see that suicide is quite intensively determined by neurobiological and psychological factors. So we can say suicidal behavior is determined. It has a multifactorial background. Suicidal behavior constitutes a heterogeneous group of behaviors. The majority of suicide victims or suicide attempters have a diagnosable psychiatric illness. So in the case of suicide attempters and the case of individuals who committed suicide, there is a psychiatric illness in most of the cases in the background, and this psychiatric illness in most of the cases is depression. Suicide has a heritable component associated with the serotonergic mechanisms, and as an important epidemiological data we can say that in 2000 almost 1 million people committed suicide in the world during that year. Facing with different facts, suicide is considered to be the second leading cause of death among college students, which is alarming data. Suicide is the third leading cause of death for youth. And suicide is the fourth leading cause of death for adults between the ages of 18 and 65. And suicide is highest in white men over the age of 85. Characteristics, clinical variables which are associated with suicide. The first is being a psychiatric patient. It's a very great risk factor. Typically depression, affective disorders, major depression or bipolar depression, especially bipolar 2 depression, schizophrenia, alcoholism. Being a male, it's a risk factor. Age as a risk increases as men age. Or the older the man, the higher the risk of suicide. Then race, whites are at higher risk than non-whites for suicide. The diagnosis I've already mentioned, the depression, alcoholism, and schizophrenia. History of your prior suicide attempt is a risk factor, we know this. Many suicide attempters later commit suicide. A recent interpersonal loss, a feeling of hopelessness, and low self-esteem. It's a very important risk factor. We have touched already the Beck triad in depression, negative view of the self, negative view of the environment, which means a kind of helplessness, and negative view on the future, which means hopelessness. And this helplessness, hopelessness syndrome means a great risk for suicide. Timing, post-hospital discharge period represent a high risk for suicide. We know that, for example, in schizophrenia there is a phenomenon which is called post-psychotic depression, when the positive symptoms are eliminated by the treatment and no hallucinations, no delusions anymore, but a depressive phase follows the positive phase, and this is called the post-psychotic depression. And many times this is the time of the discharge from the hospital, and these post-psychotic depressed patients are discharged from the hospital, which represent a risk for suicide. And among adolescents, history of drug abuse and behavior problems represent a risk for suicide. If we make a comparison between the completers and the attempters, we can see quite differences, important differences. For example, among the completers there are more males compared to attempters where there are more females. The completers are older, the attempters are younger. The diagnoses among the completers are depression, alcoholism, and schizophrenia, while among the attempters there can be also depression and alcoholism, but personality disorder is more among the attempters. Planning among the completers is careful, among the attempters is impulsive, from one moment to the other comes the suicidal act. Lethality, choice of instrument for the suicide, among the completers there is a high lethality mode, and among the attempters lower, it's poisoning with drugs, and the available of help among the completers is low, among the attempters is higher. If we have a look at the biological aspects of suicide, we can say that suicidal behavior involves three biological systems. There is an overactivity of the HPA axis, the hypothalamic pituitary adrenal axis overactivity. It's an important. The other is the serotonergic and the thyroxine system, and more polymorphisms around it are involved as a background. This slide shows us a kind of a summary how suicide behavior is established. Genetics are important, as we had seen. Mainly the serotonergic system is involved. Early life events are important, separation, sexual abuse, physical abuse, verbal abuse, or early childhood adversity is an important risk factor, which establish a kind of diathesis, a trait, a background for suicidal, a kind of predisposition. And recent stressors, recent negative life events can contribute to this, and in the development of depression, the trait markers and the state markers together form a kind of state which can lead to suicidal behavior. Among the behavior issues, we can mention poor impulse control. A kind of impulsivity is a very general background, as we have seen it in pathological gambling, for example. There is a kind of risk-taking behavior which is common. Novelty seeking, risk-taking is a characteristics of patients with suicide. Aggressive behavior and emotional lability, affective lability, beside impulsivity, is very important. There are several risk factors which are contributing to suicide. We have already touched psychiatric disorders. Don't forget depression, alcoholism, and schizophrenia and personality disorders. Past suicide attempts, very important. I've already touched this. Symptom risk factors are also important. For example, in schizophrenia, common hallucination represent a risk if the voices tell the patient to kill himself, or in depression, the feeling of hopelessness and helplessness as a separated syndrome is also very important, or the delusions of self-accusation, delusions of guiltiness. These are also very important symptomatic risk factors. Socio-demographic risk factors are also can be important, and environmental risk factors. Cultural issues can be mentioned. For example, the Werther effect. For example, a Werther effect means that suicide of a famous person, of a kind of model, can lead to the suicidal behavior of many others. And Goethe has a famous novel, The Suffering and Death of the Young Werther, which as a model worked for young males, and they committed suicide following the Goethe hero Werther, and this is important as an environmental risk factor among others. Depression is highly correlated with suicide, and there are many data on this. Approximately 60 to 80% of all suicides occur in persons with mood disorders. Major depression, and as I have mentioned, bipolar depression, and especially bipolar 2, which means that in bipolar 2 there are only hypomanic phases and major depression compared to bipolar 1, when there are bipolar true mania and true depression. And these cases of bipolar 2, the suicide risk is higher. Schizophrenia, schizoaffective disorder, also represent a risk for suicide. About 5 to 10% of schizophrenia patients commit suicide. Previously, the 10% was the data which everybody talked about. A recent meta-analysis from 2005 showed that this is a little bit too high, and about 5 to 6%, which is more which is closer to reality. Borderline, antisocial, and schizotypal personality disorders are also represent a risk for suicide. Borderline personality disorder patients many times attempt suicide. They have many suicide attempts, and we should say that in borderline personality disorder and antisocial personality disorder there are not only suicide attempts, but they are non-suicidal self-injurious behavior, as it is mentioned in the DSM-5, that cutting or overdosing is a very common phenomenon in these personality disorders, which represent a kind of tension-reducing behavior, and not every time it is a suicide, but it's more a kind of self-injurious, non-suicidal self-injurious behavior. Alcohol-related disorders also very common. Approximately 10 to 15% of individuals with serious alcoholism commit suicide. Suicide is the 8th leading cause of death in the United States. Risk for suicide, suicidal ideation, prior suicide attempt, suicide planning, family history of suicide, also important from the model, the Werther effect perspective, and also from the genetic perspective, that there is a genetics of suicide, and disturbances of the serotonergic transmission can be genetically inherited. Having known a suicide victim, especially a parent, a spouse, significant other, or a close friend, as a model can work, and contagion-related suicide, imitation, the Werther effect I have already mentioned. It's a right way to see suicidal behavior in a spectrum, where fantasies around death, suicide fantasies, suicidal intentions, suicide attempt, and completed suicide are in a spectrum, and the patient can move from the different parts of the spectrum from one position to the other. So somebody who had frequent suicidal fantasies, as we had seen, is in a great risk of completed suicide, or a person who had attempted suicide many times, and maybe the healthcare professionals see the patients as a non-serious suicidal patient. This suicide attempter later can commit suicide and kill himself. So we should take very cautiously this spectrum, and one patient can move very quickly from one side of the spectrum to the other pole of the spectrum, which means completed suicide. So in the terms of suicide prevention, we should take very cautiously everything which is related to self-harm, which is related to suicidality, which is related to suicide fantasies, suicide attempts. There was a term in the 1970s which was called parasuicide, which meant that, there are a communication type of not real suicide. This is what parasuicide meant in the 1970s. Today, this term is not really used because parasuicide decreased the attention towards a later very serious completed suicide risk. Out of patients who commit suicide, about 80% or more had a permanent contact with GPs, with general practitioners, within few months preceding their deaths. And many of them visited GPs within few weeks before their act. This is called cry for help. This is what we see many times in clinical practice, that later suicidal patient visited the GP with some somatic symptoms. The GP didn't find anything objective, sent home the patient, and a few days later, a few weeks later, the patient committed suicide, and the general practitioner didn't recognize that this patient was depressed. This patient showed a lack of appetite, sleeping problems, insomnia, anhedonia, hypothermia, and all these depressive characteristics were not recognized by the patient. And the symptom the patient went to the GP was a somatization, which can appear in depression. And this is very important to educate general practitioners on the symptoms of depression, because with this education of general practitioners, family doctors, we can prevent suicide and we can reduce suicide rates. Okay, recommendations for management of the suicidal patient. Always ask depressed patients about suicidal thoughts and plans. You will not plan ideas that were not there merely by asking. So it's very important that we should ask patients with depression whether they have a suicidal idea or not. We shouldn't be afraid that we will induce suicidality in the depressed patient. It doesn't happen. Reassess the risk of suicide at every visit with the depressed patient, very important. Hospitalize suicidal patients if it is needed, and it can be done involuntarily also. In the hospital, write suicide precautions in the doctor's order and order one-to-one protection if needed. Document signs and symptoms carefully. In the outpatient treatment, the clinician should monitor suicide risk frequently, and the usage of antidepressants can be used, and with high antidepressant usage, suicidal rates can be reduced. So the introduction of recently used new antidepressants, which have no or very limited number of side effects, is a very important tool. It's a very important instrument in suicide prevention. And remember that even though the risk factors are known, which this lecture tried to summarize somehow, it is not possible to predict who will commit suicide. So suicide will happen, unfortunately, but our goal, our intention as psychiatrists, to reduce as much suicide rates as it is possible. Factors that suggest high suicidal intent. Isolation is a very important. Act time so that intervention is unlikely. Preparations made in anticipation of death, making a will. Preparations made for the act, and communicating intent to others and leaving a note. These are factors which are connected to high suicidality. Let's see a note, let's see a sentence from a suicidal note. I cannot continue any longer. The pain has become too unbearable. Jane is not responsible. My problems are insoluble. I should have done it 35 years ago, Bill. But We can help, you can help as doctors. Most suicidal people don't really want to die. Many times they just want their pain to end. In suicidality there's a cry of pain act, and also in suicidality there is a cry for help act. So cry of pain, cry for help, and many times these vulnerable and suffering, depressed individuals, or these individuals in crisis, can be approached and the help can be given. About 80% of the time people who kill themselves have given definite signals or talked about suicide. So we should be open, we should be reflective on suicidality and try to understand what's happening inside. As a clinician, you should show your care. Take all talk of suicide seriously. Never say that it's not important, it's not risky. Everything which is around suicide should be taken very, very seriously. Listen carefully for the patient and reflect what you hear. Develop a therapeutic engagement, develop an alliance where the patient can help, where the patient isolation, which is caused by depression, which is caused by the crisis, which is caused by the pre-suicidal syndrome, which means a cognitive and affective narrowness, aggression towards the self, and suicidal fantasies. This is the pre-suicidal syndrome, or the Ringel triad. So you should try to develop an engagement with the patient, with this pre-suicidal patient, to somehow prevent the suicidal act. And use language appropriated for the age of person involved. It's very important in all fields of medicine, all fields of psychiatry, and also in suicide. Crisis intervention is very important. The detection of the crisis dynamics, the pre-suicidal syndrome, the cognitive and affective narrowing, the aggression towards the self phenomenon, and the suicidal ideation, the suicidal fantasies. This can be very much detected and can be solved during the crisis intervention method, when with ventilation of the emotions you can help the patient somehow solve the isolation and develop an alliance with the person who is doing the crisis intervention. And medication is also important. You can use antidepressants, sometimes cautiously you can use benzodiazepines or mood stabilizers, sometimes antipsychotics. So many psychopharmacological agents can be used in prevention of suicide. I have to mention, for example, the case of clozapine, which is a very good has a very good anti-suicidal effect in schizophrenia cases. Compared to other antipsychotics, clozapine has approved and scientifically shown anti-suicidal effect in the case of schizophrenia individuals, as lithium, as a mood stabilizers, also show anti-suicidal effect. Okay, outpatient management is very important. You should take care of family members and friends, and they can help an increased observation of the patient. Frequent visits are important. Medications which can reduce the self-harm are important. And I have already mentioned antidepressants as a tool in reducing suicidality. Crisis and crisis intervention and psychotherapy are also important. So this was a very short summary on suicidal behavior. It's a field of Professor Fekete, who is an expert in suicide research, but because of the pandemic, he was not able to present in this lecture. So instead of him, I tried to summarize the most important aspects of suicidal behavior and the role of the treating clinician in the reducing of suicidality among psychiatric patients and in the population too. So thank you for your attention.